Very welcome to this webinar, which is in the IRIS webinar series. And today it's my great pleasure to welcome Professor Michael West, who'll be well known, I think, to many people in the audience. He's a friend of the Irish healthcare system, I have to say, and always very well received when he does I was going to say come to present, but you're not coming to present. You're gracing us with your presence from afar. But we're very grateful to have you here. But for those of you who don't know Professor West, I suppose just to say that he's a senior fellow at the King's Fund. He's also professor of work and organisational psychology at Lancaster University. He's a visiting professor at University College Dublin with our own centre, and he's emeritus professor also at Aston University. Professor West is also a fellow in many of the psychological organizations, the British Psychological Society, the American Psychological Association, and many more accolades besides. And I suppose he was honored by receiving a CBE for his work in compassionate leadership in the NHS, a well-deserved honor, I have to say. Professor West has been working for many decades now on improving teamwork and improving leadership in the NHS and beyond, and has been doing quite a considerable body of work on compassionate leadership over the last several years. And also, I think the well-being of staff is another area that Professor West is very interested in and has contributed quite a lot to. I think anybody who has been studying in UCD and on our postgraduate programs in leadership and teamwork and healthcare will have been quoting Professor West. We just came from a session, actually myself and Aoife de Bruin came from a session this afternoon where our class who are undertaking the Masters in Leadership, Innovation and Management were doing their collective leadership module, and Professor West's work was very heavily quoted throughout the presentations. So it's nice for them, having put in all of that work and read about your work, to be able to attend and hear you speak this afternoon, as it is for all of the other members of the audience. And today, Professor West is going to talk to us about lessons from the pandemic, compassionate leadership for high quality care. So I'll hand over to you, Mike. You're very welcome.
Thank you, Ailish, for the very kind invitation to speak on this webinar and for your really kind introduction. It's a great pleasure to be with you all this afternoon and a real privilege. And I was just reflecting on the hugely difficult times that people in Ireland have had during the pandemic, and particularly back in January when things looked pretty bleak again, and the very large number of people who've contracted the virus and the large number of deaths that has been harrowing for all of the communities across Ireland, and of course for people throughout the world. And I think in times of great difficulty, there are great opportunities for learning. And I want to draw out particularly 4 lessons from the pandemic, but I think they're lessons that were there for us prior to the pandemic as well. And it's the importance of compassionate leadership and collective leadership, the importance of understanding the core needs of people in the workplace and meeting them rather than failing to meet them, the centrality of team working, of collaborating effectively within and across boundaries, and the huge importance when we're under pressure of having the time and space to be still and reflect and learn and reorient. But I want to begin by going back to January last year in 2020, before we were even aware that a pandemic, a tidal wave, was about to break upon us all. And in health and care services in Ireland and in the United Kingdom, it was clear that we were facing a crisis, probably the greatest crisis we have faced in over 50 years. The levels of stress among staff and I'll refer particularly to the data we've gathered across the United Kingdom, were at the highest levels they had ever been. We already knew that 50% more staff in our health services reported debilitating levels of work stress compared with the general working population as a whole. We'd seen a steady rise over the previous 5 or 6 years in levels of stress amongst staff, with in 2019, 40% of health service staff reporting that they'd been unwell as a result of work stress during the previous year. For people working in primary care, the pattern was similar. We were recording the highest levels of stress amongst general practitioners since the GP Working Life Survey in the United Kingdom was introduced in 1998. Stress levels were particularly high amongst nurses, with midwives reporting the highest levels, over 50% having been unwell as a result of work stress during the previous year. And the same was true in the private independent care sector and in social care. And then the pandemic struck. But even before the pandemic, we were seeing a huge rise in people's intention to quit. So in the United Kingdom, 1 in 4 nurses and health visitors were leaving the NHS, the healthcare system, within 3 years of joining. More than a quarter of student nurses were dropping out of their studies before completing them. The intention to quit was very high amongst general practitioners, with over a third saying they intended to quit general practice within the next 3 years. And just this morning, I've been looking at some new data on GPs and GP trainees and GP trainees, the vast majority intending not to work full time. We already had a shortage of 6,000 doctors in general practice prior to the pandemic. And then, as I say, the pandemic struck with all of the increases in demands, with the fear for all of our health and care staff, fear for their own lives, fear for the lives of their loved ones, and the huge challenges of seeing many of their patients die during the course of care. And in the surveys that have been done in England over the last year, it's clear that there has been a big rise in levels of anxiety, stress, and depression among staff, and particularly those working in intensive care, worrying increases in levels of post-traumatic stress disorder symptoms. In the most recent staff survey in England, published 2 weeks ago, the percentage of staff reporting that they'd been unwell as a result of work stress in the previous year has risen another 10%. So what are we to learn from all of this? I think the important thing to say is it does seem to me really important that we don't think about the future of our health and care services in terms of recovering from the pandemic. Actually, we can never go back to where we were last January, a year ago January, because that was unsustainable in terms of our health and care services. So we must think about how we transform health and care services in the short term, certainly, but for the long-term future. And that must be, I think, our focus. And there are 4, as I say, key ways I think we need to think about that transformation. And what the pandemic has taught us, I think, or what we've learned during the pandemic, is compassion is so important. Compassion's what's enabled us all to cope during this time, when we've been afraid, when we've been in pain, when we've felt as though our lives were disintegrating in some ways. The compassion that staff have shown towards patients and service users has been so moving. The compassion that staff have shown to each other, the hugs, the cups of tea, the checking in on each other, and the compassion the community has shown to elderly people living alone. I know that the commitment in Ireland to trying to ensure that elderly people can be supported to live in the community, and the compassion that people across Ireland showed in volunteering to support the NHS, to support the health services in Ireland, the HSC. So that compassion, I think, has been what's enabled us to cope. So What is compassion? Well, if I'm to be compassionate towards somebody who is in pain or distress, I have to do 4 things. I have to attend to them, understand the causes of their pain or distress, empathize with them, and then help or serve them. So attending is about being present with the other, attending, giving attention, to use Nancy Kline's evocative phrase, listening with fascination. And that gives me the basis for understanding the causes of their distress, not by imposing my understanding, but through ideally a dialogue where we arrive at a shared understanding of what the cause of the person's pain or distress is. And third is the importance of having an empathic response, of feeling their pain at some level without being overwhelmed by it, because that feeling element gives me the motivation for the 4th critical element of compassion, which is helping or serving the other person. And we know from recent neuroscience studies that empathy alone is very different from compassion and its impacts on us as we respond. So when we ask people to be empathic or sympathetic to another in pain, what we see is the activation of pain centers in the brain. That makes sense because we're mirroring the other's pain or distress or fear. Yet when we ask people to be compassionate, that's associated with the activation of reward centers in the brain. And again, that makes sense because 99% of us are hardwired to be compassionate, altruistic, helpful, because compassion and altruism is what enables us to bind together, to build social groups, to build communities, to feel a sense of connection, of trust, of safety. And that, I think, is what's been so important in helping us cope during these profoundly difficult times. But we also know a lot more now about the role of compassion in health and social care generally. A couple of years ago, 2 American academics, medics actually, Tresiak and Mazzarelli, reviewed hundreds of studies looking at the effects of compassion in healthcare. And their review was based primarily on randomized controlled trials as the gold standard of research methodology, and also on meta-analysis, where the data from published studies on the same topic is accumulated, and then we look to see what the overall trend in the data tells us. And I'm just going to show you some points from that review. It's just a sprinkling, by no means all of them. For example, the first is a randomized controlled trial of anaesthetists visiting patients prior to surgery, where they either are asked to do a normal pre-surgical visit and provide sedatives, or to show extra compassion in their interactions rather than provide sedatives. And what we see from the data is that patients in the compassion intervention are calm but not drowsy, whereas patients in the normal intervention with sedatives are drowsy, but they're not emotionally calm pre-surgery. And post-surgically, those in the compassion arm of the trial have a much lower requirement for painkillers and a significantly shorter length of hospital stay. The second is a large randomized controlled trial of patients with an early diagnosis of non-small cell lung cancer metastasized, and assigned either to normal early cancer care or to early palliative care, if you like, early and extra compassionate care. And it was a study of quality of life of patients. And indeed, what the researchers found was that quality of life was significantly better in the early palliative care condition. But what was a surprise was the discovery that those patients lived significantly longer. And we see, excuse me, similar large-scale effects of compassion, whether shown by nurses, allied health professions, healthcare assistants, nursing assistants, doctors, in the treatment of long-term conditions like diabetes and HIV. And meta-analysis reveal very significant impacts of clinician compassion in the treatment of people's mental health problems. Of course, you know, when you talk with people in health and care, they say, well, this is all well and good, but we really don't have time to be compassionate in our interactions. We're under such pressure. And that's certainly what the majority of clinicians say. But what the research review suggested was that, contrary to that belief, compassion doesn't affect encounter length. Indeed, in some of these scripted compassion interventions, the scripts were only 20 to 40 seconds long. But what's also really, I think, encouraging and fits with what I was saying earlier about the neuroscience studies is that, for example, one study asked GPs to show more compassion in all of their consultations over a 2-week period. That had an impact on their own mental health and well-being, with lower levels of anxiety, stress, and depression, and similar effects amongst nurses asked to show extra compassion. So, to summarize the many studies in this review, what they tell us is that compassion is probably the most potent and powerful across-the-board intervention there is in health and social care. And what's extraordinary is the size of the effect, greater than the effects of aspirin in the treatment of heart attacks and of statins in the 5-year risk of a cardiovascular event. So, in terms of our thinking about how we transform our health and care services for the future, we have to think about how do we create cultures of compassion? And the answer to that question is, well, every interaction we have in our health and social care settings every day is an opportunity for us to shape the culture. How warm we are, how kind we are, how irritable we are, how cynical we are, how compassionate we are, will shape the culture of our organizations or our teams. The ripples spread out from our behaviors. But the role of leaders is particularly powerful because everyone is vigilant about leaders, focused on them. What leaders pay attention to and talk about and monitor and reward, and particularly what they model in their own behavior, has a huge effect in communicating to people what they value, and therefore what the organization values. So leaders must embody compassion in their leadership. And what that means is leaders paying attention to those they lead, listening to them with fascination, who seek to understand the challenges that those they lead face by having a dialogue with them, not by imposing some understanding from afar, and leaders who have the emotional intelligence to empathize with those they lead. Given the stress that our health and social care staff were under before the pandemic and have been under since, this is absolutely fundamental, and the stress levels that I talked about. And leaders who then help those they lead by removing the obstacles that get in the way of them doing their work effectively, and or ensuring they have the resources they need, the right numbers of staff with the right skills, the right equipment, PPE equipment, the right technologies, computers that work, and the right training that give them the skills to enable them to do their jobs effectively. And this is not, excuse me, some new fancy model of leadership. We've known for 60 or 70 years that these 4 leadership behaviors are critical to effective leadership. So, and it's no coincidence that these behaviors coincide with what we understand to mean by compassion, because they're the behaviors that enable us to connect, to feel a sense of belonging. They enable us to blur the boundaries between self and other, to build a sense of connection. We know from leadership research that probably the most important skill of a leader is listening to those they lead. And we know the most important task of a leader is helping those they lead to do their jobs effectively by removing obstacles and or ensuring that people have the resources they need. And these behaviors, these leadership behaviors, are associated with better organizational performance. So whether you look in the retail sector, private sector, decades of research by people like Ben Schneider in the United States have shown the value chain from these leadership behaviors to staff satisfaction, the service that staff provide to customers, customer satisfaction and loyalty, company productivity and profitability. In England, we have been running a staff survey now for 18 years. there are over 500,000 responses every year. So we have 18 years worth of data, longitudinal data, from this huge data set. And that enables us to do the most sophisticated statistical analysis over time. And what the data show us, they tell us, is that these leadership behaviors predict the performance of NHS trusts, of health service trusts. So we see that what staff say about their leaders in relation to these behaviors predicts patient satisfaction with care. We see that when staff report high work pressure, in subsequent patient satisfaction surveys, patients are less satisfied. They don't receive the compassionate care they want. They're not treated with respect and dignity. And in organizations where there are very high levels of work pressure, poor staff well-being, then we see subsequently in those organizations significantly worse care quality as rated by the Independent Care Quality Commission, significantly worse financial performance, lower levels of patient satisfaction, higher levels of staff intention to quit, and in the acute sector, significantly higher levels of patient mortality. So for all of these reasons, compassionate leadership is core to transforming our health and care services for the future, because compassion is core to us. It's the way that we create a sense of belonging. It's the way we can support staff, and it's the way we achieve the organizational outcomes we seek. But it's also important to say that compassionate leadership, it's not some soft cushion scented candles approach to leadership. On the contrary, I think it requires a lot more courage than the easy opt-out of command and control leadership. And that's partly because compassionate leadership is about ultimately a focus on serving the communities that we're there for, of serving patients, supporting service users, of helping the people of our communities across Ireland, across the United Kingdom, to live their lives as healthily as well as with a feeling of psychological safety as they can. And so it's very much about having a strong focus on performance and good performance management, compassionate performance management. And it's not about just taking some easy consensus way forward. On the contrary, compassionate leadership will often mean perhaps going against the wishes of the people we lead in service of the communities that we're there to serve. So, I give the example of Nelson Mandela when he was released from Robben Island prison in 1993 after 27 years in prison. And he went against the millions of his followers in the African National Congress who were ready to go to war with him as their leader against the apartheid regime. And he insisted on seeking, if possible, a negotiated way forward. And against all of the odds, he was successful in achieving a relatively peaceful transition to a biracial South Africa. And compassionate leadership is about how we lead collectively as well. It's about not just what an individual does in terms of leadership, but compassionate leadership modeled by all leaders in a hospital, in a system, in a social care organization, everybody modeling those four behaviors, and about institutions modeling those behaviors. So the health and safety executive as an organization modeling compassion in the way that it operates as an institution, listening, seeking to understand, empathizing, and then helping. Because to create these cultures, we need collective leadership at every level, institutionally as well as individually. So compassionate leadership is those four behaviors, but it's also about, for the reasons I've said, it's about leadership being effective, because we're there to serve the populations in our communities and societies. And effective leadership means, we know that effective leadership is about ensuring direction, alignment, and commitment. Direction is about having a very clear, inspiring direction, which is like a beacon that guides us on a day-by-day, hour-by-hour basis in our work, not just a bunch of words on the website. And alignment is about aligning efforts across the team or the organization or the system so that people are and teams are working collaboratively together. They're not dissipating their efforts on unnecessary activities, and commitments about creating a sense of trust and motivation amongst those we lead. That model of direction, alignment and commitment developed by Center for Creative Leadership, a very big not-for-profit organization in the US, and they've produced last year a very nice summary of that model, direction, alignment and commitment by Cindy McCauley and Lynn Fick Cooper. And I can send all of the reference for this, Ailish, to distribute to people, and the slides, of course. And if leadership is not inclusive, it's not compassionate. And we've seen during the pandemic the disproportionate impact of the virus upon those who experience discrimination in society. So many more people contracting and dying from the virus, people with disabilities, people from minority ethnic groups, and an impact on those from lower socioeconomic groupings as well, a huge socioeconomic gradient. Discrimination and exclusion are health issues. So we know whether it's children excluded in the playground by their friends or people discriminated against on the basis of skin color, the weathering effects of that on immune functioning and central nervous system functioning and life chances is accumulated over time and has a huge impact on health outcomes. So inclusion, equity are health issues. We know also that diverse teams, which are inclusive and positively value diversity, that have clear objectives and positive climates, and far outperform other teams that are more homogenous. And that's true of whether it's a frontline team or a board. It's true of organizations as a whole. So for all of these reasons, compassionate leadership must be inclusive leadership. And really now is the time when we must grasp the opportunity to shape our healthcare organizations to provide models of equity and inclusion for the whole of our society, because of all of the lessons about these issues from the pandemic and the Black Lives Matter movement, so that everybody feels included by our leadership. It's no good having an above average score as a leader of how we're rated if not everybody feels included by our leadership. And the third component of compassionate leadership is that it is collective by definition. Compassion is not about seeking to increase my power and increase hierarchy and protect my power. It's about ensuring that everybody feels they have leadership rights, responsibilities, capability. One of the just most extraordinary paradoxes is that in healthcare, we have probably the largest, most skilled and motivated workforce anywhere in industry, yet we manage them largely through command and control. It makes no sense at all. Quality improvement, safety work best when they are the responsibility of people at local level, but we adopt a very top-down, target-driven, controlling type of system. What research evidence suggests is that most successful organizations have whatever their size, have no more than 3 or 4 reporting levels. And you think about in healthcare, how many reporting levels there are in a hospital, in the system generally. And it's estimated that for every reporting level you add in an organization, you add at least 10% in terms of additional bureaucracy, and it certainly suppresses innovation. And the fourth is the importance of leading compassionately, not just within our teams and departments and directorates and wards and organizations, but across boundaries. That compassionate leadership is about leading compassionately with others in other teams and across boundaries, always asking the question, how can we help? So compassionate leadership, I think, must be core to the way that we transform our health and care systems for the future. Compassionate, effective, inclusive, collective, and cross-boundary leadership. And the second, I think, really important point is that the levels of stress and intention to quit and turnover and sickness absence in our health and care systems represents a crisis in leadership. And it tells us that we have failed to meet the core needs of people in our system at work, those who deliver care. So we can put in place mindfulness programs and yoga and resilience training and so on. But if we're not identifying what the core needs of people are at work and making sure we're meeting those core needs, we will continue to bleed staff from our health and care system. We will continue to cause staff illness in the context of trying to promote health and well-being across our countries. I've had the privilege over the last 3 years, first of leading an inquiry on behalf of the General Medical Council in the United Kingdom into the health and well-being of doctors, along with Dame Denise Coyer. And then last year, on behalf of the Royal College of Nursing Foundation, of leading an inquiry with colleagues in the King's Fund into the mental health and well-being of nurses and midwives across the UK. And we used a model of core needs of people at work, a well-established, well-supported model that we called the ABC of core needs, draws on the work of DC and Ryan in the United States over a number of decades, that shows that what we all have is these 3 core needs at work: the need to have a sense of autonomy and control, rather than to feel we're just cogs in the system being coerced and directed; the need to have a sense that we're working in environments that are fair and open and honest, so it gives us a sense of control; the need to feel that we have that we belong, that we're cared for, and that we care for those we interact with in our teams and our workplaces, that we're valued and respected and supported; and the need to feel a sense of contribution or competence, that what we do through giving our energy and our efforts is we make a positive difference to the people of Ireland that we serve. And what we've seen across many settings in many countries is that these needs are not being met, and all 3 must be met for people to be well and intrinsically motivated in the workplace. So we see people feeling they don't have voice and influence, that they are just directed and controlled and given targets. And we see that people very often report feeling that they operate in climates of fear and blame, and that corrodes a sense of control or autonomy, and feeling that they can't sometimes meet their basic biological needs: access to nutritious food on your 3rd 12-hour night shift, having spaces to rest when you are exhausted before, for example, driving home, having influence over work schedules and rotas so that you can balance better the demands of your home life, your childcare needs, your care needs when you care for example, elderly parents, and belonging. When we focused on health and care workplaces, we discovered that team working is really fundamental to health and well-being, and the co-lead program at UCD has demonstrated this very well also, that stress levels, when people work in relatively stable team that has clear objectives and that meets regularly to review performance, that stress levels are on average 50% lower. There's much lower intentions to quit. There are lower levels of errors that could harm patients or staff, lower levels of injuries. Better in those organizations with more people working in such teams, what we see is better financial performance, and in the acute sector, lower levels of patient mortality. So team working, co-leadership in this way is key to meeting that need to belong. We estimate in the English system that only 40% of staff work in teams that have clear shared goals and that meet regularly to review performance. In organizations where there are large numbers of people not working in such teams, more errors, worse care quality, worse financial performance, higher levels of patient mortality, higher levels of staff stress. And it's also about this need for contribution or competence, and the core factor eroding that is chronic excessive workload. What we saw across the organizations that we studied was that chronic excessive workload characterizes the work of most staff, but it's like the pattern on the wallpaper that we no longer see. It's just accepted as part of the context. Yet we know from the research evidence it's the #1 predictor of staff stress. It's the #1 predictor of staff intention to quit. It's the #1 predictor of patient dissatisfaction, and it's the #1 factor in impeding quality improvement and innovation. So if we're not thinking about how we transform our future health and care systems in a way that addresses the issue of chronic excessive workload, then we're not addressing, what is the big gray monster in the room. It's chronic excessive workload is linked to staff cardiovascular disease, addictions, alcoholism, cancers, diabetes, depression, and early mortality. So we have to meet these core needs, all three of these needs of people at work. And we saw outstanding examples. We've seen outstanding examples across many areas of places like Nottingham University hospitals with 97 nurse councils that have time and space to meet regularly to influence the direction of the organization. Merseycare, a big mental health trust that has introduced a restorative culture rather than a blame culture, and they've reduced disciplinaries by over 70% and suspensions by over 80%, saving millions of euros in the process. We see examples of the introduction of self-rostering in organizations, Betsy Cadwaladr Trust in Wales. And during the pandemic, many places have provided free meals for staff. Northumbria, free meals and free parking. Northern Ireland provided free parking for staff across health and social care all during the pandemic. So if we can do it during these periods, why can't we do some of these things for the future and really transform the sense of control that people have? And lots of great examples of team working, and the co-lead program is a great example of developing team working in the system in Ireland. And we see, lots of examples across the United Kingdom of fantastic team working and inter-team working during the pandemic. Workload, well, it's about staffing first and foremost, and making sure that there are national workforce strategies, workforce plans for the next 10 years. Certainly Wales, Northern Ireland, Scotland have those in place. England has yet to develop a national workforce plan. There's a very, I think, positive people plan put in place for the future, but without a workforce plan, it's a bit like a shiny new car without an engine. We have to have plans in place to deliver the staff that we need, but also to retain them. Because, as I said, if 1 in 4 of our nurses are leaving within 3 years of joining our healthcare system, then there's a big hole in the bucket, and we can pour as much water in as we like, but it'll still gush out. And that's about meeting these core needs of people at work. Other ways of addressing chronic excessive workload, East London Foundation Trust, a big mental health and community trust in a very challenged area of London, continually asks its staff what they would reduce in their activities or get rid of altogether in consultation with service users. They've eliminated 85% of clinical audit activities in the context of their quality improvement culture, and they're an outstanding trust in terms of care quality. They have been steadily reducing bureaucracy and the need for managerial permission for certain training, for example, or travel to the organization's headquarters. And the use of new technologies during the pandemic has shown us how we can use technology to reduce some of the workload on staff. And we know from the work of the co-lead program and others, that when you develop team working and new roles within teams and you work more creatively together, that reduces workload and enables innovation. And that it's also about, I think, working with our community much more in the future. I think that the future will have to be about communities genuinely co-owning and co-designing health and care services, much as the emphasis in Ireland has been on how do we as communities work together to enable elderly people to live at home in their communities rather than having to go to care homes. So, and we see good examples of that. Certainly there are some good examples in England, like the Wigan New Deal, where community groups, voluntary sector organizations, local authorities, healthcare systems are working together to design how health and care will be delivered in the future. There are other examples like the Bromley by Bow partnership in London and the Well Together program in London, and further afield like the NUCA system in South Central Alaska, where the health and care system has been integrated into the community, and patients are no longer called patients, they're called citizen owners, and they've achieved amazing results in terms of reductions of addictions and suicides and alcoholism in a very challenged population by working with the local native community leaders to co-design and co-own health systems. And the Montefiore system in the Bronx, which is focused on community groups and health and care, identifying the underlying causes of health problems that lead to a young woman showing up at A&E on a Saturday night with a drug overdose, identifying the background problems of poor housing, poor sanitation, no support, no work to support her. So I think that must be the future for our health and care services, in order that we don't simply carry on with this paternalistic system of doling out healthcare to a supplicant population without the resources to meet the ever-increasing needs that we have. So meeting the core needs of people at work is central, I think, to the future of our health and care services. The third point I wanted to make, I've made very fully already, is that team working is core to how we deliver health and care services safely, effectively, and protect the health and well-being of our staff. And I'm really happy to be involved with the co-lead program in UCD and to be learning from the work that Aoife and Eilish and others have been doing these last years to develop co-leadership and team working across the healthcare system in Ireland. So I'm not going to dwell on this other than to say that interpersonal conflicts and conflicts about tasks are inevitable in teams. And in fact, I think that they're an inevitable consequence of innovation. If we're not having conflicts, we're not innovating. Chronic interpersonal conflicts are a disaster for team working, and we must never allow interpersonal differences to become chronic so that they interfere with the functioning of our teams. Other types of conflicts are inevitable. And I think in our health and care systems, we're not good at dealing with conflict in an open, transparent, ethical way. And I think everybody should have the guidance to how to deal with conflict effectively in health and care services. And this is there are many books out there, but this is a particularly good one. Amy Gallo's Harvard Business Review book, Dealing with Conflict, is a very good, transparent, clear, open, compassionate guide to dealing with conflict. And we've learned a lot during the pandemic about working in teams remotely, and just a few points of learning from that. The importance, I think, we've learned in this last year of when we're working remotely to keep realigning around our shared purpose and direction in the team, what we're here to deliver for the people of our communities across Ireland, and for that direction to be like a beacon which guides our deliberations, our decisions, our activities on a day-by-day, hour-by-hour basis. We need to embrace these new ways of working. We need to compensate for also the loss of the rich interaction we get face-to-face by celebrating people's contributions, saying thank you, by making time to chat. How are you? How was the family? How was the weekend? By bringing in everybody's contribution during the course of the discussion, so that people do feel a sense of belonging. So team working and inter-team working is vital for the future. As I say, we think only about 40% of staff in secondary care in England work in real teams, and with just teams with clear objectives and that meet regularly. So we must build back team working and collective leadership better. And the last point is the importance of taking time out on a regular basis to reflect and review. This is, I think, really key. I think what we've seen during the pandemic, whether it's been forming new teams, redeploying people, is that the need to come together into huddles and to review, to learn, to say this isn't working, we need to adapt, to change. And that has been a really effective strategy. We've seen it in emergency surgery, in combat zones, where you hear from the medical defense forces that they institute 2 patient rounds a day, 1 consultant round a day, so they can quickly learn and adapt and innovate in ways that have had a dramatic impact on emergency services in many countries. We see it in whether it's community mental health teams, wards taking time out at the end of a day to debrief, or breast cancer care teams, or executive teams, or boards, that teams that take time out on a regular basis to stop, reflect and review and adapt are much more effective and innovative than teams that don't. And the mental health of members is much better. So a recent meta-analysis combining the data from 49 separate published peer-reviewed studies showed that when you take the teams data, particularly teams that do take time out on a regular basis, are between 35 and 40% more productive. I mean, it's an astonishing figure, and it confirms what we found in the studies I've been involved with in healthcare since the 1980s, whether it's looking at primary healthcare teams or a wide range of other healthcare teams, that this having time and space to stop, reflect and learn is absolutely critical. That it's part of how we address chronic excessive workloads, because teams that do this are much more innovative and they're much smarter. And so we must build back time and space for reflection and learning in the future of our health and care services. So to summarize all of this, I think it's particularly about creating psychological safety and belonging for everybody in our health and care services through compassionate leadership and effective team working, clear direction in climates of reflection and innovation and learning rather than fear and blame, and where we have frequent positive supportive contact with each other, and where we value difference, whether it's difference in professional background or opinion or demography, and where we approach conflict in a positive way, because managing conflict positively and effectively builds a sense of psychological safety. And it's about working together with a commitment to mutual support, with compassion and with humility rather than narcissism or seeking to increase our own power and full of hubris. That's what effective leadership is mutual support, compassion and humility. And those create the conditions for trust and innovation. But the most important first step in all of this, for those of us who wish to shape a new future, is to have the courage to be self-compassionate. And you may think that sounds trite and soft cushion scented candly, as I said, but it's actually fundamental to all of those who work in health and social care, that leaders must have the courage to be self-compassionate in order to model compassion for others. And that means being self-aware in the moment, knowing what I'm feeling when I'm feeling hassled or angry or inadequate or ashamed or unworthy in the course of my work or in an interaction. And then that provides the basis for us to understand what's going on for us, to recognize the difficulties we're experiencing. and to accept them, to accept those feelings in order that we can inquire into them and then be empathic and self-caring. And again, there's a book of many books, Christine Ness book, but this one by Tara Brach is a useful introduction to self-compassion. It's called Radical Compassion by Tara Brach. And then when we, it's really important to have the courage, if we work in health and social care, or indeed anywhere else, to be empathic towards ourselves, to have a commitment to care for ourselves, because we're as worthy of compassion and care as every other human being on the planet. And when we have a commitment to caring for ourselves, that makes it more likely that we then take intelligent action, wise action to help ourselves so that we can be the best we can be, the best leaders we can be, the best people we can be, the best parents we can be, to be as happy as we can be. Because when we connect deeply with ourselves in that way, then we connect deeply with the core values that give our lives meaning and purpose and direction, like wisdom and courage and compassion. And when we connect deeply with ourselves, that's the basis then for us to connect more deeply and authentically with all of those we lead and actually all of those we interact with. So all of this begins with the courage of compassion. So Gaurav Mathagot, thank you very much for listening, and I look forward to any questions.
Thank you so much, Mike, for that wide-ranging and enlightening presentation. I hope you won't mind me saying this, but what comes across very strongly to me is your own compassion towards health workers, not just in terms of how you deliver the messages, but in terms of the focus of your own research through the many decades that you've been researching in healthcare. It really speaks to your, I think, compassion for healthcare workers at the front line. So that's very nice to see. If people have questions, would you please put them into the question and answer session, or even comments, and we'll try and get through them. But I suppose if I might start, I suppose, Mike, I was very glad to see you coming towards self-compassion there at the end, because it was something in my mind as you were speaking throughout the presentation, that it's very difficult for leaders to be compassionate if they are hurting themselves or if they're under stress or pressure. So I think compassion for self is a really important part of that. But I suppose related to that and the whole area of collective leadership is we often make the assumption that compassionate leadership is a unidirectional thing. And, you might have the formal leader, and we're talking about the formal leader showing compassion towards the people they're leading, the followers. But followers can also show compassion towards their leader. So, in keeping with collective leadership, I think everybody has a responsibility to be compassionate in terms of how they interact with other people. So it isn't, I suppose, just about the leader's responsibility to be compassionate, but also I think other members of the team showing that compassion. One other comment I wanted to make, and just going back to something you said right at the beginning about the compassionate culture of the Irish people during the pandemic. And I suppose,